Hello, everybody. We're just going to wait for everyone to successfully join the webinar. Callum, how are you?
Very well, thanks. Yeah, enjoying a bit of sunshine. We've been lacking it up here in Scotland, so it's finally arrived. How
Amazing. Yeah, make the
are
most
you?
of it. I'm very well, thank you. I'm very well. But yeah, no, the sunshine isn't currently shining here in England, so this divide, I think I'm starting to feel what it must be like. But I'm sure it will come back. I'm sure it will come
There's no hose pipe ban here, that's for sure.
back. No, no. Okay, so hopefully everyone's joined in. And like we do with all of our masterclasses that we've been doing over the last few months, a bit of housekeeping. Uh, First and foremost, welcome. Thank you so much for joining us again this month. I hope you find this particular session useful. This is on Zoom, and we have a Q&A function where we'd love to hear your thoughts, your questions, your ideas. Please use it. Myself and Callum will be looking through it and answering some. We may answer some directly on the Q&A, but we'd love your interaction. We are recording this webinar, and the video will be made available on the college's YouTube channel. And when this webinar finishes, you'll get a post-webinar evaluation. We'd really appreciate it if you could fill it out because we do read every piece of feedback and we use it to help guide future sessions and bring content that you enjoy and that you want to interact with. There'll also be a number of the links that I will share at the end of this presentation in terms of some resources, case studies, etc. So when you do see a QR code, don't worry that you need to note it down straight away. That will be in the post-webinar email. So, a little bit of an introduction for ourselves. If you haven't come to one of our masterclasses before, my name's Hussein, a GP with an extended role in lifestyle medicine based in the West Midlands. I'm one of the champions alongside Callum. And I also have a portfolio career working with a number of organizations in the physical activity sector in particular. So, for example, Parkrun and Swim England. Callum, would you like to introduce yourself?
Thanks for saying I'm also a GP up here in Scotland in Aberfeldy and Kinlochrannoch. I combine my clinical work with part-time academic research at the University of Dundee alongside joining Hussein as one of the physical activity champions at the Royal College.
Yeah, absolutely. Cam's the clever one, I'm the chatty one, and together we do get far. And do you know what? We're joined by someone else. And I'm really, really grateful to have her join in because over the sort of years that I've spent understanding, learning, and exploring the physical activity sector, and he's been really, really helpful and is a really instrumental figure in terms of understanding kind of the national framework. Annie, would you like to introduce yourself? And firstly, thank you so much for jumping on.
Oh, it's great. It's a pleasure. Thank you for inviting me, Callum and Hussein. Yes, good evening all. So I work within the Active Partnerships National Organisation. There are 42 active partnerships around the country, some of which you may be familiar with. Some of them aren't always recognisable because they have different local names, bespoke names, but we are all collectively a network across the country, all independent organisations. We're an independent organisation. We don't police or manage them, but our role is to connect, support and empower them locally, as well as those connections nationally. And that's the space that I always also work in, and hence have some previous working experience of working with Hussein on various projects and in the future as well. So yes, I think hopefully that just gives an overview in terms of who I am and where I work, Hussein.
Thank you so much. Really appreciate that. And like with all our masterclasses, Callum and I love to have this slide, which is basically saying we're going to go through a number of bits of information, topics. We may throw out some ideas, but there is no perfect way of doing this. And what I think is great is when we have creativity and sharing of ideas. So if you have any particular great cases, resources that you know of, organizations that you think are useful, please pop it in the Q&A. It'd be fantastic to see that and share that with our fellow delegates on this particular webinar. It's a bit of an outline of what we're going to be covering today. I'm going to start off by explaining a bit about what are active partnerships, because maybe some of you haven't heard of that. We're then going to move on to exploring the Physical Activity Pathways project, and that's why we've brought Annie Holden onto this webinar. She's going to take us through that. Then Callum is going to let us know about what's happening in some of the devolved nations, so both at Scotland and Northern Ireland. Then at the end, we're going to talk about our experiences as well as explore your own experiences and any feedback with regards to integrating with local physical activity providers, one of the key elements of the Active Practice Charter. So let me begin by going through what is an active or sport partnership. Now, in England, it's called an active partnership. In Wales, relatively new, but it's called sport partnerships. Now, it's a nationwide movement, physical activity, and sport network that exists to make active lifestyles the norm for everyone. Now, it's a place-based approach, and there's a real target on reducing inequalities and the gaps that are currently present. To do that, we need to look at removing barriers and how do we activate communities and individuals to access movement that works for them. And a key part of that, and definitely from my experience with my own active partnership, which is Think Active Coventry, Solihull and Warwickshire, they are crucial to help build connections between health, well-being, and ensuring that the physical activity sector and the assets out there in the community, whether that be from the volunteer sector or from the leisure sector, etc., can be accessed in a way that's fair and equitable. Now, I mentioned about sport partnerships in Wales. And depending on which sport partnership, they have different levels of maturity because it's a relatively new element that's been brought in by Sport Wales, but it's growing. And it's the same agenda and purpose. Now, Annie has come to specifically discuss one of the projects that they've been working on alongside a consultancy firm, Move Consulting. And the project is all around trying to understand the health pathways that are involved when it comes to physical activity. So without further ado, I'm going to pass over to Annie Holden to share with us the Pathways project.
Thanks, Hussein. Yes, yeah, it's a pleasure to go through this and very timely actually to explain the journey that we've been on and then the journey that we're currently undertaking over the next 2 years. There's a lot of work involved, but it's very exciting. There's been a lot of progress to date. So just to set the context, first of all, and you'll be very familiar with this, but we know that fundamentally the evidence tells us that being physically active can absolutely outweighs the risks, and those least active and those totally sedentary had the greatest gains. And the consensus statement that was released back in 21-22 now, that kind of best thing since sliced bread as far as we were all concerned. It fundamentally proved that we need to be able to move more, particularly for those people living with long-term conditions. There's greater risk of not moving. And yet, despite that, there was lots of clarification that was needed. And certainly there were lots of unintended consequences, particularly that we were hearing through our networks and other partners. So we attempted to pursue two areas of work, really. The first one is the pathways work, which I'll explain in more detail in a minute. And the second element is some work with the faculty. And then I want to explain to you how these two areas of work are now combining and then progressing through these next stages. So to give you the background, first of all, in relation to the pathways work. Now, this was funded through Sport England. They funded us, the national organisation, and we put out through a tender process and appointed Move Consulting to work in partnership with us, together with support from Coventry University. And Move Consulting managed this project expertly over the last 15 months, a 15 months period of roughly from February last year through to the end of March, April this year. And through that period, they collaborated with multiple organisations, multiple sectors, to understand how we can fundamentally support people who are living with long-term health conditions to move more. So that's looking at how to have an accessible pathway, understanding fundamentally what matters to them and what they need, as opposed to what the matter is with them, what's the right level of support that's needed, and how we can then enhance the offer and empower people to engage how they can move more. And then just to give a little bit of the background to this and a bit of the evolution of this, some of you may be familiar with a typical exercise referral scheme, the evolution of these pathways. And the origin of exercise referral schemes goes back to the late 1990s. that was underpinned through the need for behaviour change process in enabling people and supporting people to change their behaviour to be physically active. But those models are really out of date. It was more one size fits all. It was mostly accessible via gyms, via leisure services. So we realised that we needed to broaden the offer. If we were going to be truly inclusive to meet the needs of those with long-term conditions, we needed to broaden the offer, have a much more flexible approach to this, with a much more adaptable range. And through the work that we'd previously done, particularly across our network, we understood that there was huge variation at place. There were lots of examples of structured schemes of various pathways at place, but there's a lot of inconsistency across that from a design, delivery, and evaluation perspective. And there was an absolute absence of national guidance. We know from a comprehensive piece of work that Sport England conducted more recently that within NICE guidance, there's 92 pieces of evidence that says where physical activity should be pursued or should be advised. But a lot of NICE guidance is also out of date. And this all then drills down to local commissioning guidance, which we're aware there's a significant gap. So the aim of this work was to fill those gaps, and by creating those integrated person-centered systems, really looking at that personalised approach. So Move Consulted had a co-design methodology that was very much the nature of the tender. It needed to be a co-produced piece of work. They worked with over 400 different organisations and stakeholders involving mixed methods. They had 9 communities of practice, which included representation from 39 different organisations across the country. So really good representation, and those communities of practice allowed that deeper dive and understanding as well. And you can imagine, as a result of this type of work and across 15 months, they collated a huge amount of insight and intelligence that allowed us to explore and understood what was happening at place or is happening at place and where we need to strengthen that and then perhaps to broaden that. So Move Consulting, coming to the end of their project at the end of April this year, part of that was to identify what was needed. And some of the slides that I'm sharing with you are obviously just going to provide the overview, the headline information. But the extensive insight and intel that they gathered then identified that there needed to be a considered alignment from a strategic perspective, that there needed to be clear guidance for local systems working and to enable those shared priorities. We needed to really think about how to widen accessibility, what was a support offer for those individuals who wanted to move more, how we can connect those local support and opportunities to those who wanted to move more, and fundamentally increase the diversity. So recognising the invaluable role that our voluntary sector provides, those unpaid volunteers, the unstructured opportunities, as well as the more structured exercise prescription opportunities that individuals might want to access. They looked at the workforce skills and confidence and what was needed in that place, particularly around behaviour change, noting that behaviour change was central and integral to all of this work. And also what kept repeating back to us were these issues concerning risk, misperceptions across the spectrum, and that spectrum from healthcare professionals right through to our own physical activity sector. From a system-wide collaboration perspective, we know that there needs to be connections at place, what that support was needed, and the partnerships with those system stakeholders. We need to be able to share insights and learning in a more consistent way, and consistency from a data collection methodology, almost looking at what that essential data set might, or those metrics might be, to support evaluation that can then be aggregated and scaled up to consider the impact, not just locally, but nationally as well. And then looking at what's needed from the effective use of technology to improve the visibility and access. And by having that in place, then that also helps to give the healthcare professionals or those that are considering signposting individuals into local systemic pathways is to have the confidence of who they are signposting or recommending into and what those systems then consist of. And then in addition to that, they did an awful lot of work around glossary. We're very good in the physical activity sector at confusing ourselves and therefore confusing everyone else. And we need to get our narrative simple and consistent. And that was a significant piece of work that Move Consulting undertook through this process, together with the support of Coventry University. Are also going to publish some literature in relation to this. But they looked at the different areas of definition from the terminology that's routinely used. But just as a headline here, they also then defined quite clearly what do we mean by physical activity for health pathways. And that refers to the connection, processes, and partnerships that enables that coordinated network of support and opportunities for people with long-term health conditions to move more. And the ambition to achieve that definition is to create that integrated system. So we're looking at this through that systemic lens approach. We're not looking at it from an interventions perspective. We're looking at this from how we can connect across the system and have that whole systems approach to enable those individuals who have got those long-term health conditions to give them the skills and the confidence to move activity and build that into ways of life that work for them. And we looked then at the guidance framework, and Move Consulting have produced a draft framework guidance, and they were never expected to produce a completely finished piece of guidance because it's clearly one piece of ongoing work, which I'll explain more later. But what they did was they defined a development framework to support that guidance. From a systems perspective, they looked at the four levels of consideration, starting centrally looking at what's the needs of the intended audience. So very much what's wrapped around that person-centered need. Looking at the support offer and the key characteristics that are needed there, and how we can utilise the existing assets and the resources available, how we perhaps might enhance and develop some of those assets and resources, and also be very clear in terms of the behaviour change support that's needed, which is proportionate to that individual need. And then from an operational perspective of that delivery system, what are the operational elements that are required there? And then strategic development, the wraparound element where we can leverage the broader system considerations. And then within each of these levels, it was further defined in terms of further components, of which is kind of too much detail for here now, but you can see the wealth of information and rich guidance that is started to be produced here. So at the end of phase one, as we've called it, what are the conclusions here? So the report and the guidance that have been provided by Move Consulting is as a result of that co-design piece of work where they really went out to consult to an extensive level, which were then pulled together to guide that innovative approach and address those challenges and identify the support needs. And that's through that systemic wide lens, as I've talked about earlier, across health and care systems and how to integrate physical activity into those systems. It also includes examples of how to leverage existing assets and to build those trusted relationships, the clarification on definitions and terminology, as I've already stated, and then the focus on the strength-based approach. So this is the essence, this is the fundamental critical element of it. Really turning the lens now, not just from a lip service perspective, but to make sure that these pathways are accessible, they're personalised, and they have the proportionate support inbuilt into them. And then as part of the guidance as well, Move Consulting developed a system review tool, a bit of an audit approach, I suppose, to help individuals at place, the coordinators at place, the deliverers at place, to think about how they might be able to better align existing assets or identify where these can be further developed, where collaboration can be strengthened, and what system level enablers need to be challenged or developed further. And then we come on to this current phase two, as we call it, as I said earlier, roughly from April this year onwards through to March 2027. So as a result of these key documents that Move Consulting have produced, the sector guidance, the exec summary and the summary slide test, we're now going through this soft test review process, which is all part of that continuing co-production approach, playing it back to some of those individuals within the communities of practice to check with them, is this what you're expecting? Where do you think we can refresh? Where can we refine this now as we move forward, as we have always said, to further iteration of those guidance documents? We've also got a place-based focus approach opportunity where we're working with an organisation through one of our active partnerships who will have their local system players all within the same room so that we can get their insight into this early review process. And then from Q3 onwards, we hope to be able to activate the test and learn phase, where as a result of what Move Consulting have produced so far, the slight iterations to them as we've developed in these last few review and refresh processes. And we'll take that sector guidance out to some of those areas to really test and learn at place. And this is where we hope Move Consulting might be able to provide a future role moving on from here as well. This will also give us an opportunity to identify tools and resources to support the guidance framework and enhance it more. And fundamentally, this is where we will now be working synergistically with a focus on the addressing perceptions of risk as part of the ongoing frictionless work, because clearly these are two interdependent elements. So this is what I just want to focus on for the next part of this. Of my slides, just to give you the focus on where is this all coming together and how is this being driven forward. Now, the context behind this, again, as many of you may know, is that Sport England funded the Faculty of Sport and Exercise Medicine to conduct a 3-month rapid consultation across the spectrum, across all sectors, from GPs to healthcare professionals to social prescribers, link workers, across into our sectors to leisure providers. And the recommendations that came out of that proactive report, as they called it, was that there was a clear need to address the perception of risk. And a lot of those were misperceptions of risk in relation to people living with long-term health conditions and being physically active. But we have to address this fundamentally. There's a huge cross-sector appreciation of the importance of this journey. The appetite is huge in relation to willing this journey on, but the journey to meaningful change is complex, as you will absolutely appreciate as well. We need absolute clarity and understanding of the medico-legal and activity provider liability, and that's vital to the engagement and to the reassurance for all stakeholders in the implementation phase. And they also produced a roadmap, the faculty produced a roadmap which looked like a bit of a complex underground tube map for those of you who are familiar with a London tube map. But it very much encapsulated all of the different routes that needed to be undertaken and the agencies that need to be engaged throughout that. And this is where the pathways work will inform the future work that we're doing with the pathways and beyond. So one of the clear areas of work that needed to be challenged and addressed was this big shift from moving from clearance to guidance. And some of you will be very familiar with this and why we need to address it. It's a huge, big culture shift, but one that's got a lot of appetite, enthusiasm, and energy behind it. And this is where we're working closely with the faculty now to move this on, who are also working very closely and have been working very closely with Nuffield Health, in particular in relation to developing patient resources and almost an online consultation, GP consultation or replacement of, to try to shift from that clearance and the dependence upon a GP or a healthcare professional to tick the box and say, yes, this person can move on to be physically active. I don't need to tell you why, you'll understand this, but it's important just kind of fundamentally because the evidence tells us so. The behavioural change science tells us it is, so we should move to change policy and narrative around risk and benefit. And traditionally in the physical activity sector, again, as many of you will be aware, the providers have been utilising the PARQ, the Physical Activity Readiness Questionnaire, and the Health Commitment Statement as well. But we know that these have significant limitations. They've got poor sensitivity, particularly the PARQ. And in fact, evidence is very limited in relation to the quantity and quality regarding an association of pre-participation questionnaire with subsequent mortality and adverse events from an exercise-related perspective. So we do need to shift from this. And to do that, then, we're looking at developing these person-centred commitment resources to develop this replacement of a GP consultation and have an online informed consent process. And this is being developed through extensive consultation and is being piloted at the moment. So that's one big area that we're looking at, and this is how we're combining our efforts now. So this is where we're embracing these two areas of work and calling it under the moving together part, which kind of reflects everything that this is all about. And Sport England, as I said, have appointed the faculty and us to co-lead this piece of work. And just that co-leadership in itself is quite significant. It reflects that unity across the health sector from the faculty's perspective and academia, as well as our organisation in relation to the physical activity sector. So it's really a significant shift and a really important reflection of that, so that we can address what's needed to address risk and physical activity and have that cross-sector quality improvement programme approach. And we've adopted a phased approach. So there's a central advisory and governance panel in place. What's fundamental is if we haven't got all of the key players, and there are many of them, on board on this journey with us, then this will all fall apart at the end of a 2-year project, and we can't afford for that to happen. And the time now is absolutely ripe. It's essential we get this right. And I know that, for example, Hussein, from an RCGP perspective, is sitting on that, or has agreed, if you remember, Hussein, to sit on that governance panel, which
I'm
will
there, don't worry. I
be
haven't
good.
forgotten.
And our first meeting is in September. And then from that, then we have various work streams, which will include other organisations as well. And the work streams, without me going through the list, is on the screen, on the slide for you now. But you can see there as well where physical activity pathways for health guidance and talker development, that is part of the ongoing work streams. Not only will the insight and the intel gathered through the 15-month project that Move Consulting have been leading on will inform the work to date, but also will continue to be updated through the different iterations that itself goes through, as we can be informed in relation to the risk and the medical clearance work, etc. So these are two interdependent elements of work now. That's why we've embraced it under one lens of moving together to hopefully represent the work that's involved. And ultimately, the outcomes, what's the point of all this? Well, the outcomes are that we do enable these frictionless pathways to be in place, so they build in support and not those unintentional barriers that are proportionate, empowering, demedicalising. There's obviously a specific need to demedicalise this approach within our sector, bust those myths, apply the appropriate handrails, and respond to need, so that the pathways give equal weighting to behavioural support for those that need it as well. And then ultimately, we're empowering people to get active in ways that work for them. And so just finally then, we know that the barriers to activity are often very complex. There's no single solution. But what we can do is we can look to policy levers such as the NHS England's Four Ways Forward, that you're probably very familiar with now, and the elements there where we can embed this system-wide working in relation to physical activity across health and care systems, as well as leveraging Fit for the Future, the NHS 10-year health plan that's obviously just been launched. There are clear policy levers that we can maximise in the short and then the longer term as well. And then from that, hopefully, we can take that whole system place-based approach, which is driven through that asset-based community development and shared purpose, to create those conditions for lasting change. And that's it from me. Thank you, Hussein.
Thank you so much. That was really helpful. And Annie, can I ask you in terms of, because I remember I was there at the initial, just before the proactive report, in when we met up in Birmingham, and we were discussing kind of the context and the landscape. And many of those watching today may remember that the college put out a survey where we asked GPs kind of their opinion in terms of giving medical clearance, how they felt about it, where they felt it should lie. And the results were pretty clear that they aligned up with what you've just discussed, in that, we didn't feel that it was a clinician's responsibility that was over medicalizing these things. We thought that personal responsibility was key. And I wonder, from those watching as well, like, please pop in the chat if, have you had to, have you been asked about medical clearance from a patient? Maybe whether it's they want to complete an event or they've gone to the leisure centre, they come back. I'll be interested to hear what people's experiences have been, if they've been required to give that. But Annie, in terms of outline, you know how you mentioned the tube map, just to sort of explain like there's multiple steps that need to happen for this to occur. It's not like one particular shift in the law. Like there's lots of little elements that need to fall into place. I just wondered if you just want to give maybe just a few moments just to discuss that.
Absolutely, he's saying this. It is intricate, and that's why the roadmap, and it's been updated since it was launched in the proactive report, but it captured the different partners, particularly within who need to be engaged because of utilising and leaning on their expertise and experience in this space. It also identified the different areas that needed unpacking, unpicking, enhancing, developing more, and that's an outline of what was included in the work streams that I put on one of the slides. So these are all sub work streams in relation to sitting under the governance group, which will ultimately provide, as it says on the tin, the governance to make sure that we are moving in the right direction and having everyone on board. So things like the policy group, the standards and implementation group, all of these elements were outlined in the proactive report, and as you quite rightly say, these were developed as a result of the extensive consultation. And yeah, just going back on the piece that you said around the medical clearance to medical guidance, GPs, as you're aware and you've just said, and healthcare professionals fundamentally also, came back and just said they didn't believe it was their responsibility. They believe that they should be supportive of, but not
Mhm.
have to have that ultimate sign off. Yes, to provide meaningful information if requested, but perhaps more so only for those more structured exercise programs that give that increased dose. But then also we hope that that will be overcome by the advancement of the NHS app, if as
Mm.
outlined in the 10-year health plan. But also then across the board, every stakeholder that was consulted across the faculty's work in those 3 months, the conclusion from that was all that it should come back to having enabling and empowering the patient, the person, to have that responsibility and to be able to make that decision. But to make that decision as to whether they're going to be active or not, that's where they need to be empowered through the provision of resources, etc., to make those informed decisions.
Yeah, and I think that's spot on. And it was really telling because when We Are Undefeatable did some surveys amongst healthcare professionals and patients and identifying the barriers, it was interesting that the perceived barriers that healthcare professionals felt that the patient was experiencing, stopping them from getting active, they felt it was around kind of finances, time, access. But in reality, it was the patient's concerns, in particular, say pain and breathlessness sort of symptoms. And I think there's that mismatch sometimes in our understanding that although we may realize that, let's say with osteoarthritis, yes, it's safe to walk, it's safe to strengthen your muscles around the joints. But for many patients, they see it as potentially harming the joint and doing damage and causing more deterioration. So I think it's really important that we don't assume and instead we explore with the patient, what are the things they're concerned about, etc. And hopefully this kind of work can help to alleviate those concerns because it's wrong just to say, for patients, no, just go get active. We need to ensure that the information we give helps to reassure them because if they don't feel confident being active, then they just simply won't do it, regardless of what the mechanism is.
Yeah, no, absolutely.
Brilliant,
And
brilliant.
yeah.
Okay, Callum, do you want to take us through what's going on in Scotland and Northern Ireland?
Yeah, of course. Yeah, and thanks, Annie. I think my big take home from that is, as clinicians, we often see the output, and we don't see the depth and the complexity of the work that goes into the things that you do. And I think maybe that understanding of a systems based approach, although we see it in healthcare, we need to influence the sport and well being and fitness sector as well as active transport and a systems based approach. And I think a lot of what you have been doing in England is being echoed in Scotland. I'm Scottish, and I've been banging the drum to try and involve and incorporate kind of devolved nation agenda, and things are happening. It's different. It's different to down south, and certainly in Scotland, they have adopted a systems-based approach, and there's been a big focus on the physical activity sector, and they've produced an amazing physical activity referral standards in 2022, which, if you're from the physical activity sector or you're not, it's totally worth checking out because it's an attempt to standardise what is offered and delivered and those referrals. But in 2024, Public Health Scotland released a NHS physical activity pathway, which is a way of trying to standardise care around physical activity promotion in healthcare settings. So it's an evidence-based pathway, and it revolves around 5 steps targeting brief interventions. So raising the issue, screening, person-centred advice, signposting and referral, and follow-up. In Scotland, they have developed the Scot PASQ, which is the Scottish Physical Activity Screening Questionnaire, which is a 2-question questionnaire. And it's very similar to other ones you might have seen, including the GPAC and the IPAC. But it's worth giving it a Google because it's really helpful and offers a really clear outline of the questions to ask and how to really screen for physical activity within a healthcare setting. They're doing work around patient-centred advice and also addressing the signposting and referral. In each district and leisure board has a contract to deliver exercise on prescription or exercise referral schemes. And these differ health board by health board. But depending where you are in Scotland, it is worth checking out. And maybe someone, if you're from Scotland in the chat, then please do highlight some of the things that you've been doing or aware of. I want to raise a couple of resources that are identified in this pathway. The first is Alice, which is a local information system for Scotland. And Alice is, in effect, a repository for social activities, which is pan-Scotland wide. And it includes physical activity support and provision. And so what you can do is you can jump on, put a patient's postcode in the system, and it should come up with all the activities in the local area by geographical distance or by extending geographical distance. It's a really amazing way of community mapping what is available. Sadly, it's slightly dependent on area, and some places are much better than others, or much better populated than others, and particularly areas around Glasgow are better populated than other parts of Scotland. But it's a brilliant resource if you are in Scotland. And the other thing to highlight is the Movement for Health Coalition, which is similar to the coalition, the Richmond Group of Charities. So it's a group of, I think it's 19 different charities, which exist to try and support people with chronic conditions to be more active. They've got a brilliant website which hosts loads of resources to help health professionals to deliver physical activity, but also acts as a segue between the different sectors. And so jump on there to find out what's going on within healthcare, but also in lots of the other different sectors which influence physical activity. And they've also got a great podcast if you want to find out a bit more. On to Northern Ireland. I've got to admit, I'm not Northern Irish. My knowledge of Northern Ireland is a bit limited, and so I reached out to some colleagues and friends for a bit of an update. If you are Northern Irish and you're on the call, then please do chip in, comment in the chat. If there's anything that I'm missing, please do let me know. But there's a few things, or 2 things specifically, that were highlighted from a Northern Ireland perspective. First of all, they wanted to highlight Sport Northern Ireland, which is the overseeing body leading on sport and physical activity in Northern Ireland. They've got a range of partnerships, which I've highlighted here, including Walk Northern Ireland, Adventure Northern Ireland, Canoe Northern Ireland, to name a few. And on their website, they have support for many groups, including people with disabilities, women and girls, and older people. So here's a QR code to that website. If you're from Northern Ireland, please do have a look and check it out. And the other thing that the colleagues in Northern Ireland highlighted was that the Health and Social Care Trust in Northern Ireland have a physical activity referral scheme, which is well established. It's nationwide. It's delivered by the community and leisure centres. It's led by level 3 physical activity instructors. So they're of a high quality, and they know a little bit about chronic diseases. So that is Scotland, Northern Ireland in a brief overview. And I'll hand back to Hussein.
Excellent, thank you. And we're going to come on to Q&A, and we've got a couple of really good questions I'm going to go into. But before we do, I just wanted to share a couple of links. If you found this masterclass particularly helpful and you want to attend the next one, please look at the QR code on the right-hand side for that. And if you haven't already explored our hub, our physical activity hub, which has lots of resources. Now, one of the questions was from Jan, and he asked, are there resources we can share with patients to show that exercise is safe and remove one of those obstacles? There are lots of really good ones. Now, on the Physical Activity Hub, we have linked a number of them. One of them, including moving medicine, which is fantastic and has condition-specific leaflets to utilize, and it also has consultation tools for yourself when applying it within your consultations. There's also the We Are Undefeatable campaign. So as Callum briefly mentioned in its connection and relationship with the Scotland Coalition of Charities, We Are Undefeatable is a campaign run by the Richmond Group of Health Charities. So there's a number of the health charities that do a joint campaign around inspiring those with long-term conditions to be active. And there they have videos, they have leaflets, and if you log in and use your NHS email to create an account, you get to access a lot of these healthcare professional focused resources that you can send out to patients. I find them really helpful. And there's a lot of condition specific resources within the various charities. So let's say on osteoarthritis, if you go to Versus Arthritis, etc. So there are tons and tons of resources out there to support your patients. Try to make it as easy for you to do, whether it's linking it into text templates or having them on your browser in like a quick search link. Just make it as easy as possible to be able to share them with your patients, and they can be very impactful. Another really useful resource to read and to help kind of understand the background. Annie mentioned it, is that sort of consensus statement on risk that was published. It's a really useful document. It outlines a number of the key elements that we need to consider, and it sort of summarizes them into 6 key sort of shifts that we need to think about. Now, one of the other elements that I think is really important is in how Annie described, a lot of what they did was explore what was working well already in communities, what pathways worked, whether they be informal or formal physical activity pathways. And I'd really like to hear if anyone's doing good work in this space. Do you have interesting relationships with physical activity providers, whether they be formal or informal? And if you do, then we have a section on the hub, and the link is direct there on the slide. And again, all these links will be sent to you in an email after the webinar. But share with us that case study, because we'd love to promote it. We'd love to share good practice and see how this can develop, and we can get more connections with our local physical activity or national provider with a local arm. Now, to go to some of the questions, and one of the questions coming in was around, there are organizations that suggest that cardiology screening should happen regularly. So from Sports Cardiology UK website, the European Society of Cardiology recommend that all children over 12 and all adults undertaking competitive sport should undergo sports cardiology screening every 2 years. And competitive sport is defined as any sport that involves competition or regular training. So it's interesting kind of where that kind of competition ends and where it goes from kind of elite level sport. This includes a full risk assessment and screening tests. So now, I think really, really good question. And I think it's really important when we see kind of tragic, sudden athletes. And you can see that there's a concern, so let's say a blanket recommendation that all children over 12 and all adults in competitive sport undergo full echo and exercise stress testing on a 2-yearly basis. It raises a number of practical and clinical questions for sure, because when we think about the prevalence versus the yield of what we will get from these kind of assessments. For example, in young athletes, I was quickly looking at almost 1 to 50,000 or 1 to 100,000 athletes per year. So it's a tiny population that we're talking about here, and that screening everyone with an echo and treadmill testing would pick up only large impairment. So therefore, that has a significant resource implication. And although there is some data, I know that I've looked at evidence in Italy where they looked at observational data, looking at pre-participation ECGs, because in Europe, they do that quite a lot. Whenever I compete abroad in France, Italy, etc., they always want an ECG beforehand, which is rather frustrating, especially because I'm so hairy. So you have to have like a full basic chest wax every time you do it. But in observational data, there does seem to see some potential benefit, but there are no large randomized controlled trials proving that doing an echo with stress testing in every individual actually reduces mortality. So the balance of benefit versus harm, I'm not so sure on. And the BSAEM, so the British Society of Sport and Exercise Medicine, and it's a RCP endorsed guidance that focuses on looking at doing kind of the key elements for history and physical every 1 to 2 years, looking for syncope, chest pain, family history, that kind of thing. An ECG in anyone wishing to compete, and that they stratify it as regional or national level. So it's not all people that are competing, and an echo only if the ECG or exam race is concerned. So it's a bit more pragmatic, a bit more realistic, and a smaller number, given that you're focusing on regional and national level competitors. At the end of the day, this is obviously a shared decision-making process, and many will look to do this outside of kind of core NHS work, and understandably so.
You're saying I think just a key point to pull out. You did mention it is the fact that so many of the people we're seeing are people with chronic conditions that are inactive, as opposed to people that are wanting to compete competitively. And
Exactly. Yeah,
so,
yeah. It's a different
Joe,
group, isn't it? Where we're focusing here is that they're not going to enter the Olympics next week. Well, you never know, but unlikely.
and yeah, that's the target of much of Annie's work and what we're hoping to do. So yeah,
Well,
it's maybe that cardiac testing is less relevant in that population. Although being aware of consensus risk statement is possibly even more relevant.
yes, much more relevant, much more relevant. But very interesting question. Now, I wonder that we've got some really, really cool questions. So one is asking around, she's an incoming ST3, qualified level 4 strength and conditioning coach, amazing, with sport and exercise interest. Think of utilizing knowledge and experience to deliver a quality improvement project, utilizing white label personal training apps in practice to work with patients wanting to improve lifestyle, regular motivation and knowledge. So, does anyone know of any other trials or QI projects in the UK? Callum, you're normally pretty au fait with what research is going on. Anything in this space?
Yeah, I'm not so sure actually. To be honest, I suspect there is. If I'm honest, this is a really fast moving space. The We Are Undefeatable just released an app, which is an AI integrated app for people with chronic conditions. It's really amazing. You can download it in the App Store, or you could. I don't know if the free trial's over, but that is currently undergoing research trials. So they've kind of combined with the uni, and so there's a lot happening in this space. So yeah, it's worth checking out the We Are Undefeatable app.
Yeah, I do love that app. Tabaya mentioned that she's a GP trainee and she's not sure if her practice is an active practice or not. And how can she find out? Well, yes, that's a really good question, Tabaya. If you go on the Physical Activity Hub, one of the links is a map of active practices. So you can click on that and you can, in fact, see all the active practices, which, can you remember the number? It's 500 and something, isn't it? Um, is it, well, I think
I'm going
540, something like that.
five.
But
Yeah, I
have
thought
a
it was
look.
Yeah, it's
550.
about 540.
540.
Oh.
Excellent. Thank you, Gio. Yes, have a look on that map, see if your practice is on there, and then make it your life mission to get that practice on. Because very much when you look about trying to get your practice more engaged with physical activity, a key part of it is taking everyone along on that journey. And whether it is a practice meeting that you start off with, or whether you do like a social, maybe at your local park run events with staff, whatever that may be, go for it. Don't be disheartened if you don't have everyone queuing up to join you. That's pretty normal. That was definitely the case myself. But you just need to slowly find out what is it that people want to do, how do they want to do it. And for example, the we because people just that bit more engaging thing out, find a way and have a look at the map. Right. So let's have a look. Da.
Then I'm going to pull one here.
Does collectivity advice need adjusting for ethnicity, e.g., as we do with BMI ranges? Oh, I could answer that one. Callum, do you want to start with that, or do you want me to jump in for that one?
Uh, yeah, you jump in.
Okay, perfect, perfect. So yeah, interesting question there, Wasim, because I see what you're getting at, because we have now different ranges for BMI thresholds when we're classifying it into the different thresholds based on ethnicity, and that's due to the genetic preponderance of depositing fat differently. So even an increased level being visceral, and that leading to more metabolic ill health if you have fat infiltrating the pancreas, liver, etc. And so, for example, your risk of type 2 diabetes for someone from a white family background at a BMI of 30, for the equivalent level of risk in someone from a South Asian background, your BMI needs to be just 23.9. So there's a huge disparity when it comes to kind of body compositions and the impact that that can have. Now, when it comes to advice on physical activity based on ethnicity, I personally haven't seen anything specific and designated there. And I worry a little when we focus too much on the specificity of the physical activity based on things like ethnicity or condition, etc. Because in reality, if our patient is struggling difficulty, may not be that the most optimal form for the condition is actually the most doable for them in that point, if that makes sense. So I always guide it based on what the patient wants to do and what they find most accessible and what they feel they would like to start at point. And then naturally, as the confidence increases, the level of activation increases, they may be more likely to start to do more specific exercises that may be more targeted on improving metabolic health, for example, and from a South Asian background and trying to get those benefits. So generally, I would focus purely on doing what's most effective. Okay. Callum, any other questions that you found on there that you want to pull out while I was jabbering
Yeah,
away?
I'm going to pull out Najma had a question about courses for GPs for physical activity of special interest. There's a few courses out there. One, the Faculty of Sport and Exercise Medicine have a diploma in exercise medicine, which is a really interesting kind of course, which I've done, and it's totally relevant to people with chronic diseases that we see routinely in primary care.
And
Anything else,
roughly how
Hussein?
long does that take to complete?
Yeah, well, it was an exam. All it is an exam. So it was a 3 hour exam. It was online, and it was maybe a couple of months of work leading up to that with a reasonable amount of recommended reading to get through. But all those resources around the reading are available online, so you can kind of have a peruse before you sign on the dotted line and put your money in the exam.
Okay, really good. Questions come from Chadney, I think that's how you pronounce it. Apologies if I've got it wrong. But she says she works in the area of deprivation and that they have a Get Active program, which is a sort of motivational interviewing program at her practice, which can work well for some patients. She thinks a lot of patients cannot afford gym membership or classes, therefore are less likely to engage with physical activity. Is there useful advice I can give to support these patients? So these are patients that I think, from what she's trying to explain, that either access or finances are impacting their ability to potentially undertake physical activity. Any advice, Callum? How would you go about that with your patient?
I think. Sorry, I quickly zoned out. I was reading another question, so
Oh,
my
is it? Okay,
brain
I
just
can jump in. I can
went
jump in on that
back
one.
in
That's
manual
totally
mode.
cool.
Um,
Multitasking. Don't
but
get two guys to do that. No, so yes, really important question. Where I work, I have a really big divide. In Leamington, like in North Leamington, it's an area of actually affluence, but South Leamington, there unfortunately is really severe pockets of deprivation. And so what we found is that we need to be knowledgeable as to the community assets that are out there that are free or at very low cost. And actually, one of the things that we did in order to find that out is we engaged with our active partnership, Think Active Coventry, Solihull, and Warwickshire, and they helped to connect us with local groups. And what we've now done is we've created a bit of a menu. So we've got all the options for free activity, whether they be community walking groups, whether they be groups that offer free trials. So let's say 5 weeks free, and then at reduced cost. We also contacted our local leisure centre, which is an everyone active gym, and asked if we could have access to the pool for free for those with long-term health conditions that healthcare professionals had specifically selected because they were engaged and motivated to start swimming. And so for them, they get 2 sessions a week for 12 weeks for free. And then they go on to a reduced cost, what's called a social prescribing membership, which is £2 a swim. And that's significantly lower than the £5.60, which it normally is. So, yeah, I would definitely go out and find what's happening in your community that is free and accessible, and then look to reach out to various providers to ask to work collaboratively because in a way everyone active, yes, they're investing some money in providing a lot of those free swim sessions, but they're gaining because many of them will go on to social prescribing membership, and these are members that weren't there before, and the sessions they gave us were the quietest sessions during the week, so it had the smallest impact financially on themselves.
Hussein, can
Hussein, oh, sorry, Annie.
Please, Annie.
I was just going to jump in on that and just that absolutely, as you just explained, Hussein. And this is the whole point about the work that we're undertaking, so that the offer broadens. It's not just about going to a leisure centre and undertaking a program within a gym. If that suits some people, then that's absolutely fine. But it's about diversifying the offer so that then there is a menu of choice for those individuals, and one which then will address the affordability issue. And I suppose that's where it's also just important when we're discussing physical activity that fundamentally we're talking about moving more. Often it's just the basic terminology that we're thinking about. And another question within the Q&A here was around how to get people moving in their day-to-day life. And that's such a good question, because from a lifestyle perspective, we talk about stopping smoking, cutting this out of your diet, and all of a sudden we're saying, well, do more in your everyday life. We want you to do more,
Mm.
be active. But if we can think about how we can introduce it, being aware of that individual circumstances, and just think about the fundamentals of getting up out of that chair regularly, some of those basic things which might seem overly basic to us if we are regularly active, are not often to these individuals. So I would often just advise don't avoid the obvious answer. It's about moving more and recognizing that walking to the shop or getting off a bus stop earlier, getting out of the lift one floor earlier, those little things can really, really be helpful. And just to say, as Hussein suggested, find out your active partnership. To do that, you can go onto our website, and there's a finder, a map finder there, and you can look, just go onto our own website, Active Partnerships. You can Google it easily enough, and then it identifies which area you're in and which is your local active partnership. So that might also help to connect and find what's the suitability of assets available in your area.
Yeah, spot on, Annie. And if I think about the early stages when I was sort of moving into this space, the amount of help that I got from the active partnerships, both in kind of knowledge, giving me confidence, and signposting me to resources, just unbelievable. And I would really try to develop those relationships because they're such incredible assets to support you. And a lot of the questions that, for example, you've asked here, they would be able to support you with and to do. One of the questions coming in is patients suffering with mental health conditions and learning disabilities in particular pathways, are they considered as long-term conditions? Do you know if that will count or not? I'm pretty sure it is the case, but I don't know whether you know if that's the case. Yeah, we're
Yes,
getting nod.
yeah,
Excellent.
absolutely.
Perfect. Right, what's the time? We've got a couple of minutes left. Any questions that you've pulled out, Callum, that I haven't
Yeah,
seen thus far?
couple. One was an apology. There are loads of other courses on physical activity. I named one, and I'm sorry that I didn't elaborate on more, but Varun has very helpfully added a few more in there. So thank you. I'm not paid by FSIM, so the,
He definitely
the
isn't. Yes, so he talks about moving medicine active conversations. There's the
yeah,
BSLM
and the
diploma.
BSM
There's what's the Red Whale lifestyle medicine course for physical activity. There's so many. I think it's about trying to explore what's there, but also I'm going to leave the last message as we close is what Annie said in terms of keeping things simple. I remember when I was speaking to Samuel Gray, who, if you don't know, he is like the godfather of physical activity in health. And I was talking about the various different pros and cons of different forms of activity. And he said, you know what? The best movement is the next movement. And how actually with life, movement's just been engineered out. So, as a starting point, how can we just make our day more physical without having to be physically active or to exercise? So, I think what's really important, what can be a good starting point, is how do we just make our days a bit more active, and how can we engage our patients to be motivated to do those things? And a bit like with the roadmap to get us to medical guidance rather than clearance, that also has many different steps involved, and it's part of discovering kind of with the patient. But thank you so much for listening. We've run out of time. Thankfully, the team at the college will send an email with various links that we have covered so far today. So don't worry if you've missed some of the QR codes. Thank you so much for your interaction. We really appreciate it. Any closing comments from Callum or Annie?
Just thank you.
Thanks, everyone.
Awesome. Thank you and take care.